To minimize noise and distraction, all attendees' devices have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using your Q&A box. We will do our best to address all questions and comments. I will now turn the presentation over to our moderator, Garry Carneal, RadSite's President and CEO. Thank you.
Well, hello, everybody. I'm really excited about today's roundtable discussion, really looking at COPM-C CT and this concept of point-of-care imaging. And we have a great panel, which I'll have them introduce themselves in a few minutes. Just a couple of quick opening thoughts and comments. So I'm the president and CEO of RadSite, and I've been developing accreditation programs for over 25 years. And I have to say, this has been one of the more interesting journeys that I've been on in terms of really what's probably one of the best kept secrets in healthcare, and that is COPM-C CT imaging, which is a form of advanced diagnostic imaging. And it's amazing to me to see how so many systems have been installed and in use today, particularly in the dental field, and then also now really picking up the pace in the medical field, literally tens of thousands of imaging COPM-C CT systems. So today we're really going to talk a little bit about what's been going on, some of the challenges and opportunities associated with COPM-C CT imaging. RadSite kind of got into the involvement. We have been around since 2005, and we launched our accreditation program for advanced diagnostic imaging in the fall of 2013. And we really picked up the mantle for COPM-C CT when we started developing standards in 2017. And we actually, it took almost 4 years to develop the standards. And finally, in 2021, CMS, pursuant to the Medicare Improvement Patient Protection Act, approved our standards, our dental COPM-C CT standards and our medical COPM-C CT standards. And we actually launched the program about 1.5 years ago. So today we're going to touch on some key kind of issues just to kind of humanize what's going on and have people better understand this exciting opportunity. On the clinical side, we're going to ask really, how do these ADI type systems enhance clinical pathways? And what is the secret sauce behind this newer imaging acquisition technology? And how are COPM-C CT systems used in various types of practices such as dental, ENT, and orthopedics? In addition, we really want to understand the concept of point-of-care imaging. What does this mean? For example, does COPM-C CT point-of-care imaging really improve the patient experience and the pathway from diagnosis to a recommended course of treatment? But in addition to the clinical side, there's also the business side. What are the challenges and opportunities associated with COPM-C CT? And then, of course, quality and performance in terms of what, since this type of ADI modality is taken off, really mostly outside of traditional hospitals and outpatient settings, what does this mean as they're installed in different types of practices? So without further ado, I'm going to have the three experts introduce themselves. All three of their organizations have been involved with RadSite's Standards Committee on COPM-C CT since the inception. So let's go ahead and have Steve introduce himself. Steve.
Sure. Thanks, Garry. I want to say I've been volunteering on the Standards Committee for, Garry, how long has it been? 4 years, 5 years, however long it's been?
Yeah.
Fascinating bunch of discussions we've had about that and what we can do to make sure that these advanced diagnostic imaging systems are introduced to my profession, dentistry, in ways that are more important than just the installation of a new machine. And we'll talk about that in a little bit. So about me, I'm a clinician. I'm a dentist now. Next year will be 40 years. Was restorative dentistry for 32 years of that. And then a few years ago, I've concentrated my clinical practice on treating people with breathing and airway problems, snoring and sleep apnea. And my teaching efforts, though, are about moving that awareness into my profession, into dentistry, into pediatric dentistry, and helping dentists understand how they can think about how people breathe and sleep. And that means a three-dimensional kind of view of things. And so I teach that to dentists. I write about it in a book. I'm a chief dental editor of a magazine for this field. So I'm kind of all in on breathing and airway. And I love the impact that CBCT has on that ability to see what our patients are capable of and what we can do for as a therapy. Good.
Great. Thank you, Steve. Mike,
me
why don't
see.
you tell us a little bit about your background?
Hi, everyone. My name is Mike Luick. I'm Business Development Manager for Tungsten Medical Network. Tungsten is the exclusive medical distributor for the manufacturer J. Merita. J. Merita builds several different types of CT scanners. The ones we focus on are the CT scanners that are purpose-built for the ENT market. So we not only provide and install the scanners themselves, but we take care of all of the other things that are associated with ownership of in-office CT, which includes your annual preventative maintenance, your annual physicist surveys, dosimeter badges, of course, accreditation, service and support. We also provide state-of-the-art PACS software, and we're on the cusp of launching a virtual patient management software. That's us in a nutshell. Happy to be here and looking forward to the talk.
Great. Thanks, Mike. Jenna, last but not least.
Yeah, no, thank you again, Garry, for the opportunity. As being part of the standards, it's been a fun ride over these last 4 years, and hearing from all the different specialties. I think it's really great to have this roundtable format because you learn from other areas, and it's really interesting how the technology bridges in so many different fields. But I'm the director of clinical applications at CurveBeam AI. We specialize in the orthopedic market of cone beam CT. And the niche feature for us is that we are able to provide actually weight-bearing CTs as well, which in orthopedics has a different clinical implication when it comes to alignment and surgical planning. By background, I was actually clinical as well. I was a physician assistant in orthopedics and joint replacement surgery. And then prior to that was actually in the public health sector for a while. So it's been a joy watching this expand and the implications at a larger public health level that I think cone beam CT will reach in the coming years. So it'll be fun to see that trajectory.
And I can really attest that each of these individuals are thought leaders in their respective fields, and it's just been such a privilege to work with them and call them up to ask questions. So I think the first obvious question we can talk about is really the clinical pathway. I mean, with these thousands of cone beam CT imaging systems in use today and these different types of special areas, can you just provide a couple of illustrative examples of how these scans are used in kind of your different areas that you focus on? So Steve, we'll start with you and maybe just give a couple anecdotes or examples.
Well, in dentistry, actually, there's 4 places that the 3D X-rays, cone beam CTs are used. One of them is in traditional restorative dentistry. We're placing implants into the jaw to replace a missing tooth. While there's nerves and other structures that have to be taken into account there, and the only way to really visualize that is 3Ds, and that's getting very involved with planning and placement. Another place is in traditional dentistry, 2D imaging, just individual images of a tooth. They'll show the root structure that the endodontists or the root canal doctors use. So as the endodontists are able to visualize a tooth in 3 dimensions, they can map out their treatments and understand where the problems are coming from more specifically. A third place is in orthodontics. I remember when I was a dental student, and I was shown a 2D plane film of a orthodontic crowding. Great, we can see that, but we don't know where the teeth are. And so what direction do we have to move them to uncrowd them? Well, now with cone beam, there's no longer a mystery about where the tooth is or what has to be done to make room for it and put it in the right place. And then the fourth area is in airway issues, because as we expand our point of view past the oral cavity into the nose, into the oral pharynx, then being able to visualize what is in the way of breathing in those 2 areas helps us with planning out how we can ensure the patient has a nice open airway through the whole nighttime. So those are areas that I think the 4 major areas for dentistry.
That's great. And I guess when you think about airways, Mike, we also think of ENT, at least 2 of the 3, right? Nose and throat. But tell us a little bit about some of the clinical pathway examples within the ENT space.
Certainly. So really the 2 most popular reasons for a scan or what you're going to be looking at are, of course, the sinuses and then the temporal bone. And ConeBeam does an excellent job in imaging both of those areas. And not only does it do an excellent job, but it does so at 1/10 of the dose of a standard full body CT scanner. So certainly just one of the reasons why we encourage ownership and use of CBCT scanners versus the full bodies you see at traditional imaging centers or the big hospitals.
And Jenna, how about orthopedics?
Yeah, it's easy to follow because it's a different area, but it's the same problem that we're addressing on the orthopedic side. But similar to what Steve said, so in orthopedics, there's also a number of clinical scenarios where you have bones that are overlapping. And when you have a 2D picture, there's anatomy in the middle that can get missed and be overlooked. So sometimes this is fracture detection. It can be a number of cystic changes, but it's when you have overlapping anatomy, you can't see it unless you have a 3D image, and you can really scroll through bone by bone to evaluate where the problem might lie. The other area is that, the difference between 2D, 3D, but we're following very similarly the path that ConeBeam CT has taken in dental when it comes to surgical planning. The biggest advantage on the orthopedic side is we can do a weight-bearing scan, where previously we were limited to doing a 2D weight-bearing X-ray and then trying to superimpose weight-bearing alignment onto a supine 3D image that was done when the patient was laying down. And now you can get weight-bearing functional alignment information as part of your surgical planning along with 3D. And that's really helping to optimize implant positioning, as Steve said. Same thing in orthopedics, but now we're talking about total joint replacements rather than a dental implant, but very, very similar space.
That's great. Well, I'm really looking forward to getting down into some of the details of some additional kind of clinical pathways of how this, but it seems transformative. It's almost like going, if you're especially a dentist, ENT physician, or orthopedist, and we'll talk more about just this ability. It's almost like moving from black and white image to color TV, what have you. But part of this is obviously with the ability to get the 3-dimensional picture. Really, what is the technology? So a lot of these machines actually look like X-rays. So we're all familiar with X-rays, the X-ray beam, and CTs have been around for a while. Those are basically X-rays that accumulate the image through slices, and then you have this concept of cone beams. Can Mike, maybe starting with you, talk a little bit about what is this technology and how does it differ between traditional X-ray and CT?
Sure. Well, as it relates to the ENT world, of course, the 3D image that you're going to get from a CBCT versus an X-ray is going to be beneficial, but additionally, you're going to be able to see that soft tissue and bone in the same scan, as opposed to X-ray that's going to be excellent for bone. And stepping away from just the diagnostic, once you have that image from a CBCT, they can be used for image-guided surgery, which is, of course, incredibly helpful in terms of precision and accuracy.
Great. Jenna, your thoughts?
Yeah, so I would, like I said, for us in the orthopedic space, it had been this hybrid between, you had to use X-ray for weight bearing, and you couldn't get both 3D and weight bearing in a single modality, in a single imaging modality. The biggest benefits overall, I think the 3D information you get is very similar to what we think of in CT. The dose parameters are, leaning towards what we would, reference for an X-ray study. And so that's really pivotally important because you get so much more information for the dose to the patient. And on our end, maybe slightly different from ENT and the sleep space and dentistry, but in larger regions of anatomy, the biggest trade-off may be that in a CT, you have, or a multi-detector CT more specifically, you can increase the dose to a level at which you get more soft tissue information. In orthopedics, when you're imaging a larger area, it's really tailored for 3D bony anatomy. And that's just a little nuance to our area. But yeah, definitely more diagnostic information for the radiation to the patient.
And I guess we should also note that there are other special areas that COPM-C are actively being used for now, including, let's say, podiatry, chiropractic, and there's some emerging practice areas such as breast imaging. But Steve, do you remember the first time you heard about COPM-C and what were your initial thoughts? Because obviously you had been in active practice. It must have been somewhat, again, transformative when you first saw the COPM-C and realized how they could be used.
Oh, yeah. And in dentistry, we have a couple of different areas of focus. Of course, when we're looking for cavities, that's what we're known for. And we're the only part of medicine that does that. We need a very detailed, small field of view to look at a tooth or a few teeth. And so that's an area of imaging, a 2D imaging that's not yet replaced with 3D. Cone beam is not, the voxel size, the image data is not sufficient to look for cavities yet. Now, actually, interestingly, they're using AI to interpret in those voxels. That's a different subject matter. But the first time I saw a cone beam, it was like, okay, we know about panoramic images. That's a 2D film, wraps around the patient's head. The patient either sits or more commonly stands in a machine, and this thing wraps around their head. And, that was deemed to be pretty fancy when I was a new dentist years ago. So that was the advanced imaging. Then later on, as cone beam started in, it was something that was, oh, this was something specialists use. This is something that's super expensive. This is something that, you don't really need this in practice. But like a lot of other technologies, as we start to get those images in front of us. So a friend of ours has a cone beam. And so we get a patient over and we start to see these things in 3D, or we see them at a study club. It's like, wow. I mean, I can see all that. And so as a curious clinician, once we've seen it, now we want to see it all the time. So that's kind of what I remember from seeing cone beams from years ago. Yeah.
So it's interesting because under the traditional model, you would go see ENT, orthopedist, maybe oral surgeon, and you'd be referred out to an outpatient imaging center to get the CT if you needed that three-dimensional aspect. And then you would have to, that would be a whole separate appointment. And then you would go back and, consult back with the provider you were seeing. So this whole thing is now happening on site at the same time for the patient. And that's where the term point of care has come from. But Jenna, how has this really transformed the practice, and at least for your clients, in terms of workflows and patient outcomes, et cetera?
Yeah, well, there's certainly a shift in mindset that has to be adopted because you have to decide to change your workflow a little bit, right? But for those that have done it well, they're basically able to combine what would have otherwise been multiple patient trips into a single encounter at their office. And so, whether they come in and then they come back, and as part of their follow-up, they might be scheduled for their CT scan immediately prior to seeing the physician or seeing a mid-level provider. And then it streamlines it very quickly. And from a patient convenience and patient satisfaction perspective, the feedback on that end has really been tremendous. I think the patient experience is better. They feel as though they were diagnosed and initiated an accurate treatment plan probably sooner than they would have otherwise. And the physician, or the provider in this sense, is able to kind of keep that entire patient experience under their purview, both from a business model in the sense of, that entire patient encounter is owned by our group, but they're also ensuring the patient's experience from start to finish. And I think that's becoming more and more important as patients are consumers and they shop for the care that they seek more than ever.
Yeah. Mike, I assume you probably have some parallel thoughts in terms of ENT and your clients.
Sure, and I really agree with Jenna on the patient experience. That's where CBCT is going to be incredibly valuable. In the ENT world, most of the time patients are not going straight to their ENT when they have breathing issues. They're going to go to CVS first and buy up everything in the aisle that they can find to try to fix whatever is ailing them, and that's not going to work. Then they go see their GP, and then they get a referral to the ENT, and all of this time keeps ticking away, and they're just miserable the whole time. They finally see the ENT and physician, and I can only imagine the frustration where we need to get a CT scan, but it's going to be done in 4 weeks or 2 weeks, whatever it is kind of unacceptable in my opinion. To be able to do that in the same day is incredible. To be able to definitively see and diagnose what is wrong with the patient, and then this works both from the patient experience and from a business standpoint of being able to identify a patient for surgery immediately. Everybody wins. For of course those patients that are in need of surgery, to identify them the first visit is incredible. So that I'm really passionate about. Of course, I have a biased opinion, but I'm very passionate in getting these CT scanners in the office of every ENT across the country. I don't see a downside. We'll talk about pros and cons in a little bit. There's always some cons, of course, but yeah. I think it is very beneficial to all involved, the patient and the practice, to be able to have a CT scanner and use it when the patients are there immediately.
Yeah. So Steve, the dental model, we've always been used to having an X-ray machine, there. With the movement towards getting the COPM-C CT, how's that kind of transformed the practice of dentistry, or your focus on sleep apnea, et cetera?
Well, one of the things I like to point out is that, dentistry has always had their own X-ray machines, but when cone beams came around at first, because they're a big capital expense and offices weren't built to hold a machine that size, there are radiology centers around that have these machines available. But what I think about is the old game of telephone, because we can lose our ability to communicate precise details. And I think about an endodontist who doesn't have a cone beam, who really wants one for an upper right molar. And they send the patient away someplace, maybe to an oral surgery friend who has a cone beam, and they say, I need a picture of that tooth. And then the communication breaks down and they get a picture of the upper left molar. So that delays things. We send a patient away for an X-ray of a temporomandibular joint. And cone beam, by the way, is magnificent for that part of our field. And we don't get the right field of view. And so we end up with the wrong thing because the message didn't get through. Having the point of service of availability of advanced imaging makes that communication not a factor, and patient experience goes way up, because we can say, oh, I'm kind of suspicious of that upper right tooth. We get a 3D picture of it. We can turn it around and show the patient, and we get a lot more patient buy-in when it's right there. It's immediate. They haven't lost their enthusiasm or their urgency of treatment, as Mike was saying. And so we make sure that the patient sees a path toward a better future right away, as opposed to, well, sometime in the future we'll know what we're going to do.
Steve, do you think that's changed how you approach your communication and patient education, from that referral experience and then trying to have that conversation over the phone when, maybe now I'm looking at your report that I got sent, versus the ability to discuss the actual diagnostic image with them in person?
Folks are generally visually learners, Jenna, and, we all learn in different ways, of course. Right. And many of us learn a lot of things by reading papers and stuff, but there's nothing like a picture. And so when we can put a picture up in front of a patient and explain the connection between what we observe clinically, what they're telling us in their report, and look at this on the anatomy and look at it from this direction, man, what a powerful way to help folks be engaged in what their choices are for therapy going forward.
Yeah, no, I love the commentary on it, because I think it's so true. And it's hard to educate a patient about a problem that's permeating so much of their life, because to Mike's point, now I'm 3-4 doctor's appointments in, I've taken off work, I've, and then to try to have that conversation about a study over the phone, I have just always felt is such a shortcoming in our system, and helping them to really understand. And like you said, pick the best treatment plan for them, right? So that they know their options and are comfortable and confident making that decision.
At least now we have telehealth and Zoom meetings, and so we can share images over that now as well. So that's a plus for the pandemic, I guess. But yeah, but getting an image together with a narrative and a set of symptoms and a desire for change, that's the magic for getting healthcare done.
And I think to Jenna, your point is the point of care. It's really creating a more integrated platform versus a fragmented where you do have the 2-3 appointments to kind of bring it all together, and to have, in this case, a face-to-face meeting with the treating provider really makes a lot of sense. And of course, it's just not the patient that benefits, right? Also, the treating provider benefits based on the additional information. Do you guys want to just share? I'll just keep it open-ended. Let you guys respond. But what are examples that some additional examples of where it really helps the treating provider do a better job at what they're trying to do in terms of addressing the patient's issues?
If I may, from the ENT side, of course, and I'm sure the same as for the others, I'll let you guys agree or disagree. But looking at this question, of course, using CBCT in diagnostics is going to aid in the appropriate use of therapeutics, but an additional benefit is going to be able to track the improvement. So taking a CT scan at the beginning and seeing what's wrong, and then either using therapeutics in some way, or if it's surgery, whatever it is, taking another CT at a future date and seeing the improvement, and you pull them side by side and show the patient and look at this and tell me, how are you feeling now, is an amazing opportunity to definitively see the improvement that the therapeutics made.
In my field, people are sent to dentists to get an oral appliance made to hold their jaw forward to keep their oral pharynx open while they breathe and during sleep. Great, we can do that. That's not a problem. We can see the patient, we can measure how their jaw moves, we can make the device. But if they can't breathe through their nose, it's going to be a big problem. And there's not a great way for us to test that yet in an office. If we have a cone beam and we see that there's not any space up there for them to breathe through, that sets a whole different sets expectations way differently. And so we can help our patients understand what to believe in about their therapy, or maybe they should see an ENT straight away. I mean, lots of new information definitely guides our clinical recommendations.
Jenna, when it comes to hip replacements or knee replacements, does it help?
Well, we're on the verge of entering into that space, and I'm very, very excited about it. We actually started in foot and ankle and have worked our way more proximally, but it has been an interesting evolution in just the last 3 years. In my opinion, cone beam and weight-bearing CT in orthopedics has changed the standard of care already within a pretty short amount of time, where for instance, ankle replacement wasn't as popular of a procedure. So it was very routine for folks to end up with that joint being fused rather than replaced, which means that in order to alleviate pain, they're stopping that joint from being able to move rather than resurfacing it and replacing the joint surface so that a patient can continue range of motion and low impact daily activities. Ankle replacement has grown tremendously within just the last 3 years or so. And I think that's one of the biggest things around it. A lot of specialists will tell you that we weren't getting the outcomes that we wanted because we didn't have functional 3D imaging of how that patient's body mechanics and their bony mechanics would change. And so we didn't know, the best way to put that implant in until we could have weight-bearing 3D imaging. And I think that parallel, Steve, I think that's a big similarity between the path that dental took and implants, and where I think we're headed on the orthopedic side as well. I know that evolution, happened over years, but I think it followed pretty much the same suit. The imaging really changed around the implant success.
That's great. So in addition to diagnostics, we really have to start talking about interventions. And I guess COPM-C is a fairly dynamic platform, right? So there are COPM-C types of applications like called C-arms that actually help with the positioning of surgeries. Are any of you guys familiar with that? Want to make a comment on that type of application?
Well, I know that they're utilized for their low dose for almost a 3D scout, particularly in radiation therapy. So when they're delivering a much higher as a radiation treatment, cone beam CT can actually be used to confirm placement of markers in 3D space, for a much lower dose to make sure the accuracy of the high radiation therapy is targeted appropriately. So that's been another area. And then I think, Garry, you also had mentioned expansion into breast imaging as well. And, potentially seeing some changes and expansions to mammography, looking at cone beam, I think, as well.
Yeah. I mean, it really is amazing when you think about, when you look at the literature and the emerging evidence-based pathways. I think dental probably got a head start on this, but I know I've had conversations with Jenna, for example, recently, just about the evidence that's coming in literally over the past 5-10 years that really kind of showcase these applications. Before we move on, any other thoughts about, kind of examples of clinical efficacy you want to mention?
Well, in dentistry, two things are really kind of cutting edge for that. One is, again, back to the sleep apnea imaging now, they're merging the files that we can get from a scanner, which is a photographic imaging, and the cone beam CT volumes. And so we can start to make these devices we use to open the airway more precise, because we can position the jaw and take a 3D view of that one, and it's just all digital that way. The second exciting thing that's happening is when we can take a cone beam, and now we can start to duplicate the mechanics of how the jaw moves. So back to temporomandibular joint therapy and orthodontics and some fancy dentistry, when we're thinking about having to restore somebody's mouth that's been devastated by caries or trauma, and we can start to mimic how the jaw moves using the cone beam volumes. And so it's amazing how the AI and other technologies allowing dentists to see more in depth into that patient than just a 2D film could ever do.
Well, and I think along those lines, it's one of those, it's the right, you want to get the right study for the right specialty. Yeah. And how many times there's an excess or waste by someone getting radiology exams that may have not been correct, or it wasn't the best first choice. And that creates a lot of waste. And a lot of these systems can also carry out really, very specific targeted diagnostic purposes without also carrying the price tag of a multi-detector CT that is, by definition is responsible for the, the really big things. So, stroke and motor vehicle accidents and, soft tissue, abdomen, chest cancer screening or evaluation. There is certainly a role for multi-detector CTs, but I think what this is really highlighted is that cone beam CT scanners for a fraction of the price can deliver really high quality care to those specialty areas for a fraction of the price and a fraction of the dose to the patient, which we.
I was just going to say that as well. Yeah. And so to put it in layman's terms, a fraction of the dose, we've been talking about these low dose scanners. The layman's term example is 2 weeks equivalent of background radiation from walking on planet Earth. So usually when you explain that that dose to a patient, you see their shoulders drop, they're a lot more at ease. Another equivalency is a round trip ticket from New York to LA. It's the same radiation, and it gets the patient thinking, oh, like I'm being exposed to a very small amount of radiation on a plane or just walking on planet Earth. And now this machine here is going to expose me to this amount of radiation in 30 seconds, but it's still, relatively speaking, a very low dose. And for the image that you get is worth it, in my opinion.
Yeah, Mike, I think you bring up a really good point. I think if more of our payers were aware, over time as this becomes more popular, so many of the appropriate use guidelines do weigh the preferred imaging modality around dose, right? But for a number of these, that component of being lower dose and more information, I think would really change the scale in terms of, appropriate use around a cone beam CT, acknowledged as, I don't want to say its own modality, but for that specific and really important feature compared to a multi-detector CT. When we get asked, okay, well, why cone beam, instead of, well, we have a multi-detector CT, why should we have a cone beam CT too? And I think that's a really good point.
It's interesting. We had a webinar recently, which you can now listen on demand, with 3 leading physicists on cone beam CT regarding the challenges and opportunity of measuring dose during, for example, the annual physics review. And clearly, lower dose is without question compared to a CT. And I recently talked to a chiropractor who did at least a half dozen X-rays compared to one cone CT. So his use of a cone CT has drastically reduced the amount of X-rays he needs to do for his manipulations. But it is interesting to think about this whole kind of opportunity of patient safety, and there's been so much focus on radiation dose in other areas. I hope that through part of our mission together, that we can raise the public policy focus on the clinical benefits and the way that the patient actually is not only benefited from the convenience and everything we've talked about, but also obviously through radiation exposure. Jenna alluded to the payer guidelines, and we're still, our missions are all about clinical focus, but there's the business side of cone beam CT and getting paid, et cetera. So I guess I'd like to open it up to you all in terms of what are some of the advantages from a business perspective. Obviously, it's less expensive than a CT. What are some of the disadvantages, maybe how you get reimbursed? But just thought we'd talk a little bit about that, because obviously there will be providers listening to this going, well, I should really think about a cone beam CT, but we want them to go into the situation with their eyes wide open about the current advantages and disadvantages. So initial thoughts?
Well, in dentistry, we're used to billing dental benefits managers for imaging, and there's not any special codes for use for CBCT, I don't think, and there's certainly not any additional benefits available. But my colleagues that I know of that are using CBCT, just it's just part of the fee, and the fee is not that high for these things, and so the patients just end up having to pay for them. But the clinical value is so apparent that that's not really much of a pushback. In the medical world, where I treat the sleep apnea stuff, there's codes for that, but they've actually started to eliminate the benefits payable for the cone beam for my field for airway issues, not for ENT or TMD issues, but TMJ issues. But for airway issues, they don't pay for it. So it just becomes a cash pay, and we have to justify it to our patients, but it's what we do.
Well, I think one of the goals here is to line up what I call the generally accepted standards of care, what's the right thing to do for the patient based on their needs, with the reimbursement or payer guidelines. So that's part of what we have to work on. So I think there is an opportunity to work with payers to really educate them to show the clinical efficacy from a population perspective of covering more procedures, right? Because at the end of the day, it's about population health. Mike, what are your thoughts on this area?
Sure. So it's kind of speaking more broadly, what are some disadvantages? Let's start there. it's a capital expense. It's a lot cheaper now than it was 10 years ago, but it's still 6 figures. It's money. And you're either going to take a loan out for it or write a big check. It takes up space. They're relatively small, but you still need space for it. Some of the scanners we work with are ballpark 3 feet by 5 feet, something like that. So you'll need a room that's 7 by 10, give or take. You need space for it, period. Then you need, oftentimes, not always, depends on multiple factors, but you may need additional radiation shielding on the walls, depending on how many scans a month you're taking, utilization of the rooms next door, a couple others. So, here's another disadvantage. There's a lot that comes along with with just owning an office CT, so much so we've made a business around it. So there's a lot. We mentioned it before, all the things that we do: preventive maintenance and physicist survey and dosimeter badges and service and maintenance and accreditation. There's things that you have to do with an office CT. So sure, there are some disadvantages, but what are the advantages? And both from a business perspective, and this ties in, is if you're doing the right thing for the patient, it's going to come down to the bottom line every time, if that's what you're doing. If the patient experience is better at your office than it is somewhere else, you're going to make more money. But just kind of speaking plainly, this having an in-office CBCT would allow you to identify those patients for a particularly profitable procedure, which is a balloon sinuplasty. And if in one case, if you're referring that patient to get the image done somewhere else and it takes 2, 3, 4 weeks, sometimes they just don't get it at all. At that point, they're frustrated. It's just things happen. They fall off. And now that patient is gone. And the typical ROI for a CBCT is identifying one patient a month for the balloon sinuplasty will pay for the scanner. And if you're usually ballpark, it's like 15, 17 scans, just the scan by itself will pay for the scanner. CPT code 70486 is the one that's most widely used for the sinuses, 70480 for temporal bone, but the average reimbursement would 15, 17 patients a month, something like that. And most of our practices are doing double that amount.
So Mike, I'm hearing from you that the clinical and financial benefits outweigh the cost, although we need to be aware of some of the current challenges to kind of optimize the opportunity. Jenna, what do you see from your perspective with your clients?
Yeah, no, I agree. It's very, very similar on the orthopedic side. Mike, you described that beautifully. I think the other thing that we're seeing between medical and dental, and it is happening with different reimbursement models now, about folks that are looking at more value-based care potentially and creating bundles and bringing imaging in-house is certainly really helpful in knowing and creating your own costs, right? So you know what providing that service is going to be. You can create your own pricing. I think we're getting better on the medical side about having that conversation, as Dr. Carstensen said. I mean, I think dental they have more experience. They've been doing it longer, about having that conversation with patients about if something isn't covered, but we really believe this is better, and then setting up programs and ways to do cash pay. I know from a surgical planning perspective, we're starting to see a lot more of that. So if the CT is denied, if it's part of your practice, you can still offer a cash pay option. And I think we're going to see more of that. And I think we'll also see more of it as specific surgical services are becoming bundled. And you can kind of set your own pricing in that way too.
Another aspect of the business is the culture that you set up. Because if a patient comes to see you and you have this advanced imaging, then you can show them fancy things that they couldn't see somewhere else, or they couldn't see at their last dentist office or last orthopedist office, then that's a different, marketing thing that you can do for your practice as well. Look at us. We're on the leading edge, and we're trying to lower the dose to get the images that we need, and all the marketing messages that can be built around that. So that's part of the business as well.
It's funny. Clearly, healthcare is not static. I'm thinking back about 6, 7 years ago, I was hired by the American Telemedicine Association to kind of take their telemedicine accreditation standards to the next level. And one of the first things I had to do was really work with the standards committee to put together a typology of what telemedicine really represented, kind of documenting the clinical pathways of the business side. And obviously, accreditation was just one of many different activities to kind of frame it. And then you have something like the pandemic happen, right? Where telehealth, telemedicine just took off. And thank goodness we had kind of these foundational pillars in place. I think the same thing's really, quite frankly, happening now with COPM-C on the medical side. I do think it's a little bit more advanced on the dental side, but obviously the general notion of quality and performance is really important. And people want to know that that this, again, advanced diagnostic imaging happening at the point of care, not necessarily an outpatient imaging center or hospital, is really benefiting the patient, and it's the right thing to do. The world is changing. People are used to now telemedicine, telehealth. What are some of the different quality and performance activities do you all think are important? I heard the word accreditation. I don't want to be too promotional, but obviously, accreditation is one starting point where you come up, there's a rich tradition. The very first accreditation program I brought to market back in the 1990s, we had moved from indemnity insurance to HMO insurance. And then there's something called point of service, which became PPO. So it's really a couple of accreditation organizations that framed what a PPO is today, which is a primary network delivery system. And it was accreditation that kind of led the way. It could be the same thing as kind of happening here. But what are your thoughts about the quality and performance kind of issue and how this moves the ball forward?
Well, for dentistry, it's still just a marketing message, because we don't traditionally have to have a lot of quality assessments done in a dental office, because the machines are pretty self-contained. I mean, we don't do a lot of settings on them anymore. The folks come in, they install them, they train us how to use them, and we push buttons, and they do what the magic happens. Well, when we think about this, then COPM CTs for dentistry is pretty similar. But I've loved being able to put together the accreditation requirements for RadSite, for example, Garry, and I don't mind saying that in this forum, because it'll help dentists understand that they are actually doing something pretty fancy here, and they need to pay attention to the details. And I think that elevates our profession, goes right back to marketing. If a dentist office can say, yes, we have this machine, but we're also paying attention, that's a great place for them to set their flag in terms of quality care for their patients.
Right. And of course, there's a lot of things related to it, right, Steve, in terms of the professional qualifications, who's the medical and clinical director, who's the interpreting provider, who's the technologist, how's the machine being checked. And I think we're still in an environment where there's not a whole lot of regulation on COPM-CT compared to traditional X-ray or the advanced diagnostic, other modalities. So I do think that initiatives such as accreditation could be helpful, and perhaps that's why CMS mandates, that COPM-CT systems be accredited if you're imaging a Medicare beneficiary and you want to be reimbursed. But Mike, what are you thinking?
So I'm looking at the question, what steps can be taken to optimize this emerging type of advanced diagnostic imaging? I would say step one is get an in-office CBCT scanner. That's going to help a lot. And I don't mind saying this on this forum either, because I mean it, but having accreditation like RadSite, like what you guys are doing, helps to standardize the rules of CBCT across multiple disciplines. And it's going to segue into our next question that I know we're going to talk about, is why has this proliferated into some of these different disciplines at a different rate? And RadSite accreditation, for example, is going to help standardizing those rules, which I know I'm getting ahead of myself. We'll get into in just a moment.
And Jenna, you mentioned actually, kind of the move towards value-based purchasing. I mean, that is going to capture more and more of how payers, whether you're a public agency or private, health plan, are going to be, paying for, care, whether it's imaging or some other type of services. But what are your thoughts in terms of, how you kind of promote or think about quality and performance?
Yeah, well, I think accreditation for anyone, it primarily, you mentioned it's a business, and to be able to bill for Medicare on the medical side, you need to be an accredited facility. But I think every patient also wants to know that the place that I am seeking and receiving this care is qualified to be providing the services that I'm getting. But I think as this does get standardized and the modality demonstrates its value to the commercial payers as well, being an accredited facility automatically lets those commercial payers know, okay, they have all of the appropriate staff in place, they have their policies and procedures, and staff are all, have checked out. And I think if, as a commercial payer, they're also going to want to know that they're getting their money's worth and that they're paying for a quality service. I think if the advanced diagnostic imaging is being provided outpatient versus a hospital versus a physician office, as long as it's good quality, we're seeking the same service, right? And I think that if we can standardize that and help educate and help the payers feel confident about what they're paying for in terms of, the service for their customers, I think that ends up being a win-win across the board.
Yeah. I've been impressed with what's called the technical component. I mean, a lot of creation programs, regulations are what I call, again, process and structure measures, but as part of this evaluation, you're actually looking at the performance of the imaging system. And in the tradition of the ADI equipment, you do need to have typically a third-party physicist come in and do physics testing. That's require a lot in state regulation. And many COPM-C CT applications, there's absolutely no requirement to do that whatsoever. So you have machines that have been in service for a long time. So outside of following the manufacturer or QC requirements, there's maybe not been any check on a system. And I imagine over time, a system should be looked at by an expert. And the other thing too is the quality of the images, right? So you do have this different technology in terms of acquisition of the COPM-C CT image with the voxels, but you still have the reconstruction software, and you have the person interpreting the image, which is the call to action related to that image. And it's good to kind of have a quality check as to that interpreting provider, whether they're a radiologist or orthopedist or ENT or whatever, to make sure they're actually interpreting that image correctly. And also the field of view, right? Because you may be picking up something beyond just what you're looking at, and what is the call to action if you see like a mass that's suspicious, and what do you do? So I do think it's important to look at the quality and performance of COPM-C CT systems more holistically, and to reflect some of what we've already been doing for advanced diagnostic imaging or even for x-rays. Any final thoughts on quality and performance before we move on? Because of course I live and breathe that stuff, right? So as we said, so one of the things is, again, I just gave the example of telehealth, telemedicine. I remember in roughly circa 2016 presenting what I was doing with the American Telemedicine Association at a payer conference. And I just got a bunch of blank stares because there's a lot of buzz about telemedicine, telehealth, but they certainly were by and large ready to pay for it. Now, of course, it's kind of standard care, but we obviously do have these kind of parallel universes with COPM-C CT on dental. And there are actually a lot of good payer guidelines you can download from the web. On the medical, it seems to be being adopted a little bit more slowly, but you have this really strong evidence base that now is merging with peer-reviewed studies. What can we just talk a little bit about the adoption curve and what's been going on? I mean, I guess Steve, start with you. Why did dental take off so much? I've heard estimates is between 30,000 and 50,000 dental imaging systems already installed. What led to that quick pickup compared to the medical, which is maybe 3,000 to 5,000 imaging systems that are installed, even though now it's growing exponentially, but over the past 10 years, what led to that kind of bifurcation?
I can't speak for medical, but one thought I have is that as we look at it from a dental standpoint, we've had 2D films, and now we have this new capability. So it's something new, different, and expansive. And I'm curious about whether medical sees this as a step down, pardon me, a step down from spiral CT back down to something that's less capable, less whatever they might add to that. I don't know enough about that, but from dentistry, I think it's just something, dentists are like a lot of other people. We like shiny new toys too. And so we see this as something that's better than what we had before. And so we're curious, and we have space. And if we had the stand-up panoramic 2D machine, many of our choices for getting additional capabilities don't occupy any more space. So we have a room for it. We've built in the shielding. We know where the buttons are. And so the step up wasn't that big of a deal for that. And so they want to do that. Yeah.
Mike, Jenna?
I was going to say, I think the reason why adoption has been slow for medical or simply different is there are just different rules between medical and dental, and those rules vary from state to state. And so again, RadSite helps with that standardization. But in my opinion, I think some of the rules on the medical side are more strict. Steve and I were talking just a little bit ago, and sounds like there are some similar rules that I was saying. I know in the South for the dental to have CBCT, there's not a need for an operator barrier, and sounds like I think it's in Washington there is a need for an operator barrier, correct? Yeah. So it's interesting, and even in the medical, just the medical by itself, there are totally different rules from state to state as to, for example, who can push the button. So in some states, you need to be an MD or a licensed RT, and in other states, you simply need to be trained on how to push the button, and that's it. You don't need any letters after your name to push the button in some states. And then there are some states in the U.S., 3 in particular that I know of off the top of my head, that have a certificate of need where cone beam, you can't have a cone beam in office CT. Michigan, Virginia, and Connecticut, I believe are the states.
There's quite a few. So the CON is something that certainly comes up on our end as well. That certainly comes up on the medical side. And Mike, I apologize if I cut you off at the end there,
Perfect. No.
But I think that, but similarly, in terms of different rules, I think there's also an expectation on the patient side that their medical insurance is going to cover everything. And I think there's a shift there, but more consumers are used to having to pay a portion of their care for dentistry. And that helped adoption, because I think that from a business model, the dentists and oral surgeons and number of folks on that side were able to sit down and really run the numbers and say, okay, if I make this capital investment, what do I need? What do my volumes need to be to offset that? And they have control over that. And I think we're starting to see more of that on the medical side. But there's a lot of folks that spend a lot of administrative hours on things like prior authorization on the medical side. How is this going to work into our workflow? How, we're also still having to run X-ray at the same time. Do I need extra staff to run both X-ray and the CT scanner now? Do I, all of those things come into play in getting it successfully adopted in your practice. But then some of the distinctions between medical and dental in terms of coverage, I think have also created the adoption has been slower because of that. But I think as we get to more cash pay bundles, patients are asking now about cash pay services outside of dental and in the medical space. I think, we'll start to see that catch on.
So we're almost out of time. I mean, this hour just flew by. I wish we had 2 hours, or we may have to schedule part 2, because I feel like we just scratched the surface. And quite frankly, I'm going to listen to this webinar and take notes what you guys said. So I really appreciate it. We did get one audience question, and there are probably a couple more, but I wanted to just raise this issue as we're wrapping up. And that is there differences between the cone beam CT imaging systems themselves? We are having a webinar in January that's going to talk a little bit more about this, but if you're a provider looking at a cone beam CT imaging system, is there a range of quality of systems themselves? And of course, I guess as a patient, you'd want to look for that accreditation seal from RadSite or another accreditation organization. But in terms of the equipment, is it pretty much all standard, or is there a range of the quality of the equipment, if you will?
You know, it's been a while since I shopped for them, but I'm sure anytime you have a field where there's, 10 to 20 different offerings, there's going to be a stratus between, one that costs this much and one that costs that much. One company that's been doing them for 5 years and one company that's been doing it for 25 years. So I'm sure there's differences. Yeah.
I can only echo that. So we have models also based on specialty. So for us, some folks might only be looking for a foot and ankle. If they're a foot and ankle group, that's the key feature that they're looking for. Same might be true for upper extremity. And some of our newest models are based around versatility for a multi-specialty group where you have a mix of different orthopedic specialties, but they all want to use the same CT scanner. And so our newest model is really focused on that versatility. I think, Steve, you alluded to this a little bit, and maybe this is part 2, Garry, but I think the other component that is going to be, widely expanding is it's not just now the image itself, but it's what are you doing with that image or the software package, or, heck, Mike, like you said, they built a whole business around this. And so that might be another offering when considering a vendor. And a model that really suits your needs for your practice. It might be some of those additional services and components or softwares now.
Right, and Mike, we're going to
agree. Sorry, go ahead, Garry.
Yeah, Mike, we're going to give you the last word, so go ahead.
Thanks. Well, I'm going to agree completely with both Steve and Jenna. And Garry, to answer your question, are there differences between CBCT scanners? The answer is absolutely. We, in particular, have 2 different scanners that we go to market with, and one is a stand-up scanner, and the other is the more traditional where you sit down in the scanner. In between the 2 of them, there's a $40,000 price difference. There are differences in image quality between those 2, of course, differences in our respective competition comparison, but in stand-up versus sit-down, there's all kinds of pros and cons between the 2, but the stand-up scanner, just a quick one, is you have less height restrictions. If you have someone that's really tall and they go to a sit-down scanner, you might have issues with your field of view. Or if you have someone that's really tall and a stand-up scanner, you sit them down and you lower the scanner to their height. And same thing goes with if you have a patient that's wheelchair bound. They don't have to get out of their wheelchair. You can wheel them right into the space, lower the scanner to their height, take the picture, and you're good to go. So yeah, in short, absolutely, we could certainly do a part 2 on that, on the differences between scanners. And then I love what Jenna said too, is what you do with the image after you have it. There's PAC software. Yeah, there's all kinds of stuff that goes along with the in-office CT for sure.
Well, Jenna, Mike, Steve, this has been so informative. I'm so indebted, and I do, we will need to think about how we continue this discussion. It's so important to get the word out on all these different topics. And this, of course, is one of many complimentary webinars that we offer. I'm going to turn it over to Patty to kind of wrap things up. But again, thank you so much for a very informative roundtable discussion. Patty?
RadSite would like to thank our moderator, Garry Carneal, and our panelists, Dr. Steve Carstensen, Mike Luick, and Jenna Roller. Just a reminder that today's webinar has been recorded and will be available through our website. If you have additional questions, contact us at info@radsitequality.com, and we will answer your questions for you the best we can. If you've enjoyed this presentation, be sure to check out the webinar page on our website for past webinar recordings. We hope you will continue to join us for upcoming webinars. Thank you.
Great. Thank you, guys. Really appreciate it.
Thank you.
Thanks. It was
Thanks,
a
Mike.
pleasure.